Iron is a Group 8 transition metal. In the human body, it operates as the ultimate biological electron shuttle, driving the mitochondrial respiratory chains that power her cellular bioenergetics. But iron's core biological utility is exactly what makes it so hazardous. The physical ease with which it alternates between its reduced ferrous and oxidized ferric states makes free ferrous iron highly reactive. Unbound iron spontaneously reacts with cellular hydrogen peroxide. This drives the Fenton reaction, generating volatile hydroxyl free radicals that cause massive lipid peroxidation and immediate organelle destruction. To survive, the human body is forced to sequester virtually all of its iron inside complex, hollow protein architectures like ferritin, transferrin, and heme. The clinical pathologist is tasked with measuring this highly guarded system. But because the body actively hides iron, standard laboratory assays are frequently distorted by biological and analytical variables. Extracting the truth from an iron panel requires mapping complex diagnostic algorithms, troubleshooting pre-analytical interferences, and executing precise acute toxic protocols. Misinterpreting these derived indices is not an isolated laboratory error. It directly dictates incorrect therapeutic pathways and causes lethal delays in clinical management. Before analyzing complex systemic pathology, the laboratory must guarantee a clean, accurate analytical baseline. The data is only as reliable as the physical sample. The most common point of failure occurs before the sample even reaches the analyzer. A difficult phlebotomy draw introduces severe pre-analytical mechanical stress. This schematic outlines the standard automated chemistry assay used to measure serum iron. To extract the measurement, the sample is treated with an acidic buffer. The buffer forcefully dissociates ferric iron from its transport proteins and reduces it to a soluble ferrous state. This freed iron binds directly to a chromogenic ligand, like ferrozine, forming a stable colored complex. However, if mechanical stress ruptures the red blood cells during the draw, the massive concentration of iron locked inside their hemoglobin leaks directly into the serum phase. This hemoglobin iron cross-reacts with the colorimetric reagents, generating a massive artifactual spike in the spectrophotometer reading. This is pseudo-hyperferremia. To prevent this corrupted data from reaching a patient's chart, laboratories enforce strict optical gating. Any sample with a visible hemolysis index exceeding the established threshold is automatically rejected. Even with an intact sample, strict timing is required to establish a baseline. Serum iron exhibits extreme diurnal variation. As hepatic clearing peaks, circulating iron levels drop by 30 to 50% by late afternoon. Without rigorous pre-analytical gating and standardized morning collection times, a perfectly healthy patient drawn at 4 p.m. could be misdiagnosed with severe iron depletion, or an artifactually hemolyzed sample could trigger an invasive workup for iron overload. Internal iron availability is governed by the hepcidin-ferroportin axis. This acts as the master biological switch for systemic distribution. When a patient develops severe systemic inflammation or an active infection, the immune system floods the circulation with the cytokine interleukin-6. This directly upregulates the production of the hormone hepcidin in the liver. This diagnostic flowchart branches downward from a low mean corpuscular volume to separate microcytic anemias based on how hepcidin alters cellular transport. High hepcidin degrades ferroportin export channels, actively trapping iron inside macrophages to starve invading pathogens. The classic presentation of true iron deficiency anemia isolates perfectly on this grid, characterized by exhausted storage pools resulting in low serum ferritin, an elevated total iron binding capacity as the body attempts to scavenge missing mineral, and a critically low transferrin saturation. But critically ill hospital patients introduce a severe diagnostic complication known as ferritin inflation. Because ferritin is an acute phase reactant, systemic inflammation artificially drives its synthesis. Looking at the anemia of chronic disease pathway, the profile shifts completely. Inflammatory cytokines push ferritin levels into the normal or high range, while the total iron binding capacity actively drops. This physiological response creates a dangerous clinical illusion. The elevated ferritin actively masks a concurrent iron deficiency, providing a false laboratory assurance that tissue stores are adequate. To resolve this ambiguity and see past the inflammatory mask, the laboratory initiates a specific reflex protocol, measuring the soluble transferrin receptor. When cellular matrices face true tissue iron starvation, they shed transferrin receptors into the serum, driving the measurable concentration up. Crucially, this receptor level remains entirely stable during pure inflammatory states. Relying solely on a normal ferritin level in a patient with severe sepsis or rheumatoid arthritis guarantees missing a severe state of tissue iron starvation. Moving to the opposite extreme, the laboratory identifies refractory homeostatic dysregulation when a patient's transferrin saturation permanently exceeds 45%, paired with ferritin concentrations climbing past 1,000 micrograms per liter. This split screen compares two distinct mechanisms of extreme iron accumulation. On the left, we map type 1 hereditary hemochromatosis. A genetic mutation in the HFE gene physically blinds the liver sensor network, completely blocking the synthesis of hepcidin. Without hepcidin, intestinal iron absorption runs continuously. This excess mineral spills into the plasma as highly reactive non-transferrin-bound iron, depositing into parenchymal tissues and driving the slow, decades-long progression of macronodular cirrhosis and the pancreatic beta cell destruction known as bronze diabetes. This hereditary accumulation requires years to cause organ failure. Acute toxic overload occurs in hours and is almost exclusively caused by the accidental pediatric ingestion of concentrated iron supplements. A massive oral dose of ferrous sulfate immediately burns through and bypasses the enterocyte regulatory pathways, forcing high concentrations of free iron directly into the vascular space. Tracking the toxicity timeline on the right, breaching a peak serum iron threshold of 500 micrograms per deciliter initiates immediate, cascading clinical collapse. At this concentration, the massive volume of free circulating iron uncouples mitochondrial oxidative phosphorylation. This bioenergetic collapse drives rapid cardiovascular shock and an extreme high anion gap metabolic acidosis. If the patient survives the initial cardiovascular shock, the subsequent free radical destruction of the liver parenchyma triggers fulminant hepatic failure within 2 to 3 days. Chronic overload slowly fibroses organs over an entire adult lifespan. Acute toxicity causes lethal metabolic shock in hours. The laboratory must handle the reporting of each state with an entirely different analytical urgency. To safely calculate these saturation indices, laboratories determine the total iron binding capacity through one of two primary methodologies. This equation calculates transferrin saturation. It requires either the direct measurement of binding capacity, achieved by saturating the sample with excess iron and using alumina columns to remove the unbound fractions, or the indirect derivation, mathematically calculated from immunonephelometric transferrin levels. Because critical diagnostic and phlebotomy decisions hinge directly on this resulting percentage, the laboratory maintains exceptionally strict quality control. The analytical precision must maintain a coefficient of variation of strictly less than 2.5%. This tight analytical precision is mathematically required to counteract human biology. Native serum iron exhibits massive within-subject biological variation, naturally fluctuating up to 30% from day to day based on sleep cycles and dietary intake. To filter out mechanical or physical collection errors, the laboratory employs an automated delta check protocol. If a patient's serum iron value shifts by more than 100 micrograms per deciliter within a 24-hour window, the automated system stops the result. A failed delta check forces the clinical pathology team to manually investigate the specimen. They must rule out ex vivo sample contamination, such as blood drawn upstream from an active intravenous fluid arm, before releasing data into the medical record. If the laboratory fails to maintain rigorous mathematical quality control over the inputs, the resulting derived indices degrade from precise diagnostic tools into dangerous guesswork. High-fidelity laboratory data is only valuable if it dictates specific, necessary changes in the patient's therapeutic architecture. For deficiency states, clinicians select either oral ferrous sulfate or direct intravenous replacement to bypass the enterocyte blocks entirely. For hemochromatosis, the data guides weekly therapeutic phlebotomy to strip excess mineral out of the reticuloendothelial storage core. This is a standard laboratory information system terminal. When a toxic panic value exceeding 500 micrograms per deciliter is verified in a pediatric patient, the clinical pathologist actively intervenes. They append a critical value alert note explicitly recommending the immediate initiation of intravenous deferoxamine chelation therapy. Deferoxamine acts as an emergency chemical scavenger. It binds directly to the free circulating ferric iron, forming a stable water-soluble complex called ferroxamine that the kidneys can rapidly excrete. These acute interventions are the ultimate expression of active diagnostic stewardship. But stewardship also requires knowing when to stop testing. Because the reference change value for native iron hovers between 70 and 80%, minor biological fluctuations easily mask true physiological shifts. Ordering repeated daily iron profiles on stable medical wards offers zero diagnostic value while continually depleting the patient's blood volume. By mastering the intricacies of the hepcidin architecture and enforcing rigorous algorithmic logic, the clinical pathologist actively guides the hospital away from diagnostic illusions, ensuring every intervention is grounded in physiological reality.